Good afternoon and welcome to this panel 2 discussion. We have some distinguished guests with us. And what I'll do is, as I call everyone, I'll have them give a short introduction of themselves as we move forward. This is obviously a very critical topic at a critical time in our nation's history. And I certainly want to start off by commending the mayor and her team for putting this together at this very, very important juncture. This is an issue that we should all be aware of, and not just aware, but be proactive about being part of the solution. And so I certainly have the distinct pleasure to be with such an august group today to discuss this. What I'll try to do is to keep this moving, but we'll go around first and start with some introductions. I'll start with Zia, if you can introduce yourself briefly, and then we'll go from there.
Hi, thanks for having me. My name is Zaya Malawa. I'm a pediatrician and a public health practitioner in San Francisco. I work for the Department of Public Health in San Francisco, and I run a program called Expecting Justice there, where we look at how we can address racism directly as a root cause for birth health inequities. Thanks.
All right, Binny.
Hi, everyone. My name is Binny Chokshi. Thank you so much for having me. I am also a pediatrician that works right here in Washington, D.C. at Children's National Medical Center. I'm an adolescent medicine physician mostly, and at Children's, I've run a Healthy Generations clinic. I'm one of the co-medical directors for that clinic, which is a medical home for parenting teens. And we really try and infuse our clinic with a trauma-informed approach to create a medical home for these teen parents and their families.
All right, Amanda.
Hi, everyone. I'm Amanda Latimore. I'm faculty in the Department of Epidemiology. I'm a social epidemiologist, and a lot of the work that I do involves providing technical assistance to public officials across the U.S. on the overdose crisis.
All right, and last but not least, Dr. Cooper Owens.
Hi, I'm Deirdre Cooper Owens, and I am a historian, a professor, and I also am the director of the Humanities and Medicine program at the University of Nebraska-Lincoln. And I'm also the director of the program in African American history at the Library Company of Philadelphia, the country's oldest cultural institution.
All right, and I am Wayne Frederick. I'm the president here at Howard University. I'm also a practicing GI surgical oncologist. So we'll jump right in. One of the issues, obviously, today, as we look at the issue around maternal health, is the issue of trauma and the role that trauma may play in a pregnancy and also both pre and post in terms of the relationship and how a woman may view herself and be viewed by the folks around her. So maybe we could start with you, Dr. Malawa, about what you see and what your thoughts are about how we even define what that trauma looks like.
Thanks. So I think, historically, stress is one of the very few things that we can say definitively is causing these premature births that we're seeing so disproportionately in Black women, Indigenous women, and certain other communities of color. Increasingly, research is indicating that it's not just stress, but specifically racial stress has a causal relationship, meaning that it can be now seen as a cause for some of these birth inequities. And so I think that trauma, yes, as a whole, but in particular, we need to think about the trauma of experiencing racism and some of the economic, financial, and educational manifestations of racism as a major driver of some of the birth inequities that we see.
And Dr. Latimore, just to build on that, the constant weathering that some of these structural inequities cause can manifest themselves in so many different ways. What are some of the ways for those who are listening today that you see that in the work that you do, and any other issues that you think we should elucidate here as we talk about the trauma and that stress?
Right. Well, some of the systemic cross systems impacts that Dr. Malawa talked about have very important consequences for people's health long-term across the life course. So that chronic exposure to mass incarceration and lack of resources and food insecurity, that leads to what we call allostatic load, which affects the immune system and long-term can produce higher rates of cancer and autoimmune disease. So for every traumatic exposure in childhood, you're looking at a 20% increase in autoimmune disease. Cancer rates are higher, type 2 diabetes, and substance use disorder is another important long-term consequence.
And Dr. Chokshi, you probably see this in terms of what types of developmental issues children may have, as well as their social, not just their physical development, but their social development and the impact. And as well, when you look at the rest of the siblings or even their peer mates in terms of the environment that they may be in. What are some of those manifestations you tend to see?
Sure. There are challenges with emotional regulation and memory, performance in school. Obviously, all of the systemic issues impact a child's ability to attend school in the first place. You know, right now we're talking about COVID, there's the digital divide, an inability to actually participate in school obviously leads to, increasing the inequity for education. So all of those things combined can really challenge the development and youth being able to hit those milestones.
And Dr. Chokshi, anything you want to add to that as well?
Yeah, I definitely agree with that. And I also just wanted to, point to, I see it in kids for sure, but in my teen parents, the literature has shown again and again that teens who have unintended pregnancies, and the unintended is important there, have had disproportionate rates of exposure to traumatic experiences. And I think that is really important for us to understand in order for us to be able to take the best care of our youngest mothers, that their pregnancies develop within a context of adversity at times. And in order for us to best meet their needs and to help their stress levels and to help the developmental outcomes for their children, we need to recognize that and respond with a trauma-informed approach. And so I agree with Dr. Latimore. I see those developmental outcomes in the children that I see, but I think it's important to even go upstream and recognize the ways in which they are, being rooted.
And since you touched on the issue of teen mothers and teen pregnancy, what are some of the things that we should take away from the impact of trauma on those young mothers, as well as you made a point about unintended pregnancies versus planning. And I think that's a critical point, especially when we think about teenagers as well. What are some of those factors and their own long-term outcomes and potential after having a child at that young age?
Yeah, I will try and make just a few points. I think I could probably overtake the panel talking about how we could talk about teen parents, but I really appreciate the question. And I think the one thing I would say is that I do a lot of work with respect to trauma-informed care and educating my colleagues, medical trainees, interdisciplinary health professionals, community members on what approaching patients and clients and families and communities with a trauma-informed approach entails. And that's really thinking about reframing from thinking about what's wrong with somebody to instead what happened to them. And that's so tremendously important across the board with respect to healthcare, but with teen parents specifically, because there's so much misunderstanding, there's so much judgment that comes their way. And as a result, the healthcare that they are offered can be suboptimal, and they also access healthcare less because of the lack of respect that they receive. And so I think it's so important for us to recognize that if we are going to meet the needs of our youngest parents, we need to meet them where they are and provide them with the same respectful, patient-centered care that we provide everyone.
And I'll just add to that and extend this, what happened to you to what's right with you is an approach where we're not pathologizing people for their trauma and recognizing their assets and bringing that to the table in our response to the trauma.
And I'll just provide something a little different. We've had reason here at Howard to look at the outcome of students who come from single family homes, predominantly single mother homes, and they actually tend to do better than our two-parent family homes as well, which I think speaks to the resilience of Black women. And so that takes me to Dr. Cooper Owens. Resilience is something that often is discussed when we discuss this topic of maternal health. It's kind of in spite of what is occurring around us. What are some of your thoughts about the basis of that resilience? And as we look forward as well, what are some of the things we should be thoughtful about as we examine structural changes that we can put in place to be more supportive?
Yeah, thank you for that. Often I joke, I said, I sometimes feel like an interloper because I wrote a book on the history of racism, gender, and American gynecology. And so I sit in a very different world. It's a humanities world and not one that you all sit in, which is the medical world, but medical humanities has brought me in because people are really interested in how did we get to this place of maternal crisis, but in particular, Black maternal crisis. And so, you know, like many things in this country, it starts from a space of anti-Blackness. When we see the ways that, in particular, Indigenous women, but also Black women, most of whom were enslaved when they were brought to the Americas, unfortunately, that literally sets some of the foundations for how the medical industry was created. And so all of a sudden, you start to have a very particular way that doctors see Black people and white people, men and women. And even laws are then changed around the ways that Black women have been exceptionalized. So for instance, a child inherits the status of the mother if that mother is enslaved. And that goes against everything that European colonists had brought. So the resilience comes in the form of how does one heal in the midst of trauma, even if you don't have the language to name it as such. And so you build community. So whether that's by blood or, you know, it's an old school term, but I think a lot of people are familiar with it, with fictive kin, but you build community, you build kinship. You are able to hold on to and to tweak some of the traditional ways of healing. And so the things that we tend to now call music therapy or art therapy, these people were infusing in the midst of their own healing. And so that's the resilience. I think as we move from that period of the 18th or 19th century, what you started to have in the late 20th and in the 21st century is a democratization that happens within medicine, but also within the academy. And when that happens, you start to have people who center subjects who look like them. And so it's not surprising to me that many of the panelists here who are pediatricians or epidemiologists are Black women or women of color. And so we tend to focus on those populations because we saw that there was a dearth of studies and research that were being done. And so when we started to pivot the conversation to focus on patients, you start to come from a position of, maybe it isn't race that's wrong, but it's racism that's wrong. Maybe it is a way that we can move from patient blaming to a more holistic view of healing. And so I think the resiliency comes in where we now have a kind of widening of the scope of what holistic and effective healing measures actually mean.
And just to piggyback on that, because I think as you make that very, very critical point, I think it's important for us to understand the history of it. But as we go forward, I think it's important for us to understand how we control those. And I would say, you know, very openly here at Howard is an example of something that we have to change. We've had 17 men as presidents, including myself, and hopefully I'll be the last before my successor. 70% of my undergrads are women. When I started, one permanent female dean of 13. We now have, and we've gotten up to as high as 10. But clearly, part of that also is the structure system. We have a mayor who is a strong advocate for women and for maternal health. And so when we look at that, what are some of the things in our health system that you see us doing as we go forward? You look at the project that the mayor has sanctioned in Southeast DC and bringing obstetric and pediatric care there is a critical, I think, piece of laying the groundwork. But based on what the resilience has been built up, what do you see going forward as key initiatives that must be undertaken?
Ooh, I don't know if a local person. I am a Southeast DC girl. I grew up.
That's why we're asking you. And you're not an interloper, by the way, because the humanities are critical to what we do. So you're not an interloper. It's a backbone of what we do.
Yeah, thank you. I think, what's important, and you know this, President Frederick, there are not a lot of Black medical schools. We have Morehouse School of Medicine, we have Howard, we have Meharry. And the sad thing is, during the era of segregation, we actually have more nursing schools and medical schools set up for people of color. So we have to be able to widen that. We are talking about a really white medical field. Does that inherently mean it's bad? No, because I don't believe in biological determinism. But what it does mean is that you have now had those people who are coming in more recently saying, wait a minute, the foundation is shaky. And so there are a few folk who are listening. I think the other part of it, we are in academia. I think 3 of us are attached to academic institutions. Most academia, largely white, 86% of PhDs are white, right? And so once again, here you had to have people who look like me, born in the late 20th century, who are writing about a past that wasn't even really a secret. It's just, I decided to say, instead of looking at the doctors and the hospitals, why don't we look at the patients, right? Because I had a particular focus on that based on my own training coming from an HBCU, being a Black woman, all those kinds of things. So I think a part of the structure is literally dismantling or excising, if I can use a medical term, excising those parts that are diseased, right? And being able to shape institutions that pay attention to the ways that these communities have been mistreated, how they are being harmed. So that means perhaps not providing healthcare based on a high income tax bracket for certain communities, not having doctors be switched out like temp workers in certain hospitals in poor areas, right? That sometimes people are like, I think I met with Dr. Jackson, but Dr. Jackson's at 2 or 3 other hospitals during the rest of the week. Those kinds of things need to be in place structurally. But how do we get that when the population is so small in terms of people of color who are in academia, who are in medicine? And so, that's kind of the I don't have an answer to. Maybe.
I'll underscore one of the things that we could do is support our local HBCU and University of the District of Columbia. So we can start there. I think, again, the mayor has done a fantastic job of supporting that institution and raising its stature, not just in the city, but nationally. So Dr. Chokshi, I want to get back to you, because you deal with adolescents. So you kind of see the manifestation of the perinatal environment that you alluded to in the teen mother. But I wonder, in the kids, after they pass that infant and childhood state and they become adolescents, what is the psychological, the physiological impacts of some of that trauma that you may see manifest itself in adolescents who come from a circumstance where they've dealt with that trauma, their mother's pregnancy was traumatic for the social reasons that we've mentioned. What are some of the things you see manifesting in them as adolescents?
I am very excited to answer that question, but just for the prior question that you asked, I also wanted to say part of the answer is including our patients and families in the solutions that we are trying to, in the brainstorm sessions for the solutions that we are trying to find couldn't be more important. So many of us sit in a room, try and think of what might work, but truly the voice of our patients and families is not being brought to the table enough. So I just felt like I would be remiss if I didn't say that. So apologies for adding my own thoughts.
No apology. And I think, again, kudos to, the district and the mayor's office for putting on something like this. I mean, we have to have these conversations in order to be able to bring that out and to the forefront. So I think your point is well taken.
Yeah. And in terms of the adolescence, adolescence is so interesting because it's a time of sensitive neurodevelopment that can almost be as sensitive as the early childhood years of the 0 to 3 years. And to answer your question, anecdotally, what I see is a myriad of things, truly. So, mental health is a big one. We see depression, anxiety, and we see patients who come to have a evaluation for ADHD. And really, if you ask the right questions and sit down with the patients and really take time to understand their experience, you recognize that what they may be manifesting are really symptoms of PTSD. There's such an overlap between ADHD and PTSD. And, that's something that I'm passionate about, is really making sure that we are helping our patients and diagnosing them appropriately and factoring in trauma into the differential diagnoses that we have. We see it in, difficulties in school, difficulties in peer relationships. I already mentioned unintended teenage pregnancy. And so I think really across the spectrum of pediatrics, but also adult medicine, it's that idea of being mindful of trauma and recognizing. I always advocate for universal trauma precautions. And so I'm not a big fan of screening for traumatic exposures. I think that this is the way that we should practice healthcare across the board for all of our patients in every sector. And so I would say that the same holds true for adolescents as it does for younger kids, but also young and older adults.
Dr. Malawa, with that in mind, what are some of the interventions that we could put in place early on, and how early can we start putting those interventions in place in order to help the healing process and to ensure that some of the long-term effects that we just described do not manifest themselves?
Well, to answer that, I just want to kind of go back to looking at adverse childhood events in particular. And when we look at a lot of the adverse childhood events that have been most studied, so many of them are impacting people of color differently because of racism. Like, for instance, one adverse childhood event is if you had a parent who was incarcerated. But if you are of a community like Black and Indigenous people, Latinx people that are disproportionately incarcerated in this community because of racism, then racism is literally producing adverse childhood experiences for these kids. I worked at the Baby Child Health Center, which was a clinic that really looked at adverse childhood experiences for many years, and we would find a lot of moms who would get a trauma screen at the beginning of their visit and then kind of name that, I know that I have my kid in an unhealthy living environment, but I don't have the financial resources to move. So what am I supposed to do? And again, these are mothers who are people of color who are disproportionately impacted by economic alienation. So they don't have the wealth or the income to be able to make moves to protect their kids from what can be really hard living situations. And so when I think about interventions, like, yeah, sure, therapy and stuff, but what the critical intervention here would be to address racism, frankly. And I think that we as a medical community are very reluctant to do that. The health officer of New York City published a commentary in the New England Journal of Medicine in 2015, where she basically did a search across the entire journal for articles that mentioned racial health disparities. And she found something like 450 articles that mentioned racial health disparities. But of those, only 15 mentioned the word racism. And of those, 6 were book reviews. And I think that goes a long way to kind of explain how we in this field are very comfortable naming racial health disparities, but we are not comfortable naming the root cause of racial health disparities. And so we spend a lot of time, building resilience and providing therapy after the fact, but we really need to think about this from a preventative perspective, I think, because A, it will be the most effective way to deal with this, but also it's the only ethical way to deal with this. Like, if we are seeing that racism is literally taking a lifetime toll on kids of color, then there's only one right thing to do, and that is to stop being so darn racist.
All right, so with that in mind, I think that's not just compelling, but forceful. This morning, I read an article from the New England Journal of Medicine about racism in sickle cell. And as a sufferer of sickle cell myself, I'm homozygous for sickle cell. I was stunned that this was published in the New England Journal of Medicine, pleasantly stunned. I've probably read it twice already since this morning, and intend to read it again tonight for bedtime reading, because that is not an article that I expected to see there. And I think it goes to the very point you're making. So with that in mind, Dr. Latimore, what are some of the things when we talk about the systemic racism that creates the environment specifically that our listeners, that even the mayor's office could take away from this to say, this is something that we need to go change? And also public health officials all around the country, what are some of the things that we can say to them today? These are the things that you can begin doing this afternoon to start impacting exactly what Dr. Malawa, I think, has highlighted, and appropriately so. Right.
Well, we are in the midst of a social justice movement. So I think it is, the stars are aligning for us to do something about mass incarceration. police brutality. Black communities are over-policed, brown communities are over-policed, and they're 10 times more likely to be arrested in some locations, 3 times more likely to be fatally shot in police encounters, despite the fact that they're less likely to be, carrying contraband or carrying a weapon. They're highly impacted. So, I'm of the opinion that there's health in all policy. And if we can change some of those policies that reduce over-policing, reduce incarceration of our Black and brown communities, then that directly relates to health. It keeps people employed. Once you get incarcerated and you get in that cycle, it's hard to get employment, housing, food security, and all of those things trickle down into maternal health.
So with that in mind, the very practice of medicine, based on what we've already heard in terms of the biases that people bring to the table when they interact with the patient population, is part of the issue. And we're in the middle of a pandemic, as you rightly pointed out. There's a social justice issue. Is there something or some things that you have observed, Dr. Chokshi, that is occurring right now that you're concerned about, that may be accentuating the very trauma and some of the outcomes in this moment that we should all be aware of and ultimately be trying to prevent, and not wait till after the trauma, as Dr. Malawa rightly pointed out?
I'm concerned about many things, but specifically with regards to this, I think it's really important for us to recognize that COVID-19 in itself represents a community trauma. It is a period of uncertainty. It's a period of loss of control. People don't have any sense of safety, and those are the exact characteristics of a traumatic exposure. And certainly, to go back to the definition that Dr. Malawa gave in the beginning, trauma is subjective. We cannot state for our patients or their families that something is traumatic for them, but just from a community standpoint, as a pediatrician, I can see the effect of this community trauma on our patients. And so I think that we all, as a city, but also as a nation, have to factor that into our response, to recognize that across the board, people are unable to access the things that keep them well. People's jobs are at jeopardy. They can't access food. Community resources are limited. Mental health access is limited. But on top of that, this is felt greatest in our patients who may already have a history of other adversities, because then you have this traumatic exposure being layered on top of a history of trauma that already exists, which is an even more dire situation. And so if we want to respond to this, we really have to recognize it from that perspective, and we have to take care of each other. And as healthcare institutions, we should be willing to do that and recognize that COVID-19 is not just an infectious disease. It is a pandemic, and many other pandemics have had much data that has come out of them years later showing the traumatic effect of the pandemics. And so if we want to meet the needs of our patients and families, we have to recognize that. And then if we recognize the social justice movement that's happening concurrently, we need to recognize that this is a perfect time for us to right some of our wrongs and really take action to build strengths, build resiliency, and help individuals access the care that they need and the resources that they need. And for me, specifically in my practice, I just see over and over the need for supportive mental health services. And if I were to make one request to, our mayor, it would be to help our patients access mental health services, because it's such an investment in society, and the dearth of resources is really alarming and upsetting.
Okay.
I would argue we are in a trifecta of epidemics between COVID, racism, and the overdose crisis. We really have an opportunity to also provide, in addition to mental health care, greater access to medications for opioid use disorder and other therapies for substance use disorder.
Yeah, most certainly. And I think with that in mind, Dr. Cooper Owens, my mom lost her husband, my dad, a month shy of my 3rd birthday. And I have a younger brother as well. So she had 2 very small kids when that occurred. And as we discuss this topic and we think about the pandemic and how many, and disproportionately affecting African-American populations in which family structures are being broken because of the deaths that are taking place, and also the long-term effects of having COVID. The Black woman still represents, in my opinion, the core of the universe. Definitely, it still is in my universe, and it's going to be in our community's universe. And having to carry that burden is obviously accentuated with what we've heard here. We talk about incarceration. Clearly, African-American men are more likely to be incarcerated, but who do they leave behind to carry that burden? When we look at those things, and we were talking a bit about structure, intervention, making appeals for what should happen. What are some of the things communities can do themselves that does not involve legislators or does not necessarily involve the government? What can we do for ourselves? What self-love can we apply that would be helpful?
I love that last part of your question, what self-love can we apply? Because I think that love is the defining framework. Love is the methodology, right? So love becomes the practice that can help save us all, because from love emanates empathy and compassion and thoughtfulness. And these are things that are needed in everything that all of my esteemed colleagues just mentioned. So from mental health care to a new way of thinking about substance abuse or overuse, right? For raising our children. And so for me, it kind of, because I'm the historian, I'm always like, wait, there was a blueprint left. I promise y'all, it ain't hidden it ain't hidden. It's actually in a book. We just have to know which books to get. Right. And I do a lot of public speaking. People are interested in the history. And I will tell them, guess what people did centuries ago that we're now picking up in the 21st century? They created mutual aid societies. They created benevolent societies. So there was no legislation. In fact, the legislation was patently anti-Black and anti-woman. And so these people were like, let's put our pennies, our coins together, and let's create a space so that we can bury our loved ones, so that we can feed our families and people in the community, so that we can educate our children. And so I saw that, especially during the beginning of this newest pandemic, in majority Black urban cities, New Orleans, out of Baltimore, DC, New York. I used to live there until last year, a number of mutual aid societies. I think that's important. I think the cultural institutions that sustain us become really important. And I don't necessarily mean formal ones. You know, I love HBCUs. I went to 2 of them. But churches, I think social clubs, cultural clubs, the fraternal organizations, all of those kinds of things, even the informal spaces where we entertain each other. So when I think about music therapy, when D Nice, comes and plays music, right? That emanates from a South Bronx culture that was informed by people who came from the Caribbean, and they just wanted to feel good in the midst of a Bronx that was burning around them quite literally. And so he brings this to us in the best way we know how. So those are things that don't cost money. Those are things that don't require legislation. People are often saying, well, what are Black people doing? We are our own worst enemies. And I'm like, are you not seeing what we are doing every day to sustain ourselves? And so that's why I really thank you for ending that phrase on self-love, really as praxis. That's what we do. And it ain't new. We've been doing this for centuries. It's not new, right? And that's the most radical and revolutionary act. I do want to say, added on to what everyone else has said, and I know this is not surprising to you, this is about maternal and infant health. And we know that we're facing this crisis. I was shocked. This was in July. I'm going to do something with a healthcare agency based in Germany, but the medical director is a Black woman from the South, educated in the US. And she said, and I was just shocked, that on average, women of African descent have low-level inflammation at almost any point during the day. And I was like, so what does that mean? Because of the stressors that we face, unending, racism, sexism, a lot of isms, literally your body's trying to repair itself at night, but you have these low-level cortisol levels, all of these things. And I'm saying, my God, the fact that your body's supposed to restore itself during sleep, but it's also trying to fight off inflammation because of these stressors. And that's another point that Dr. Malawa was talking about with this kind of anti-Black racism that just seems unceasing. So I often in my talks by telling the good white folk in the audience who are like, Dr. Cooper Owens, I'm a believer now, what can we do? And I'm like, stop raising children who are anti-Black. Because the statistics show that when they're entering into medical schools in the 21st century, they literally believe things that were taught in the 1800s, 1900s. So stop raising people who are anti-Black and entrusting them to care for those who look differently or live in a different zip code. It really starts there.
So two things I'll say to tie that to Dr. Latimore because I'd love for you to comment on this. One is on that issue, and since you mentioned Germany, I had the opportunity to go to Berlin and meet with this young guy had put together almost like a book club in a I want to call it a library, but it was really like a one-room space, and they were interested in coming to Howard. And I got in there, and they wanted me to take a picture with them. And as I stood up to stand in front of them to take the picture, I looked over my shoulder, and there was a picture of Toni Morrison. And before I could articulate to them that she was a Howard alum, they gave me her entire bio. So one of the reasons I always preach that self-love is because I think that Black women can be so uplifting to one another and that role model, but we have to make sure that we do prize them in that way and that we do lift them up. And then to tie that issue, because I don't want Dr. Chokshi to take this personally, there's an article in the American Medical Association Journal on unconscious bias, published a few years ago, and it looked at implicit bias. It took the starting medical students at Johns Hopkins, predominantly white, and posed different questions to them. One of the questions was a white woman, booth operator, and a Black man, lawyer, and it said which one is more likely to answer, to be able to sign an informed consent, to understand it and sign it. And the majority of that class, and I think that medical students, the day before they start medical school, are the most altruistic people. They pick the white toll booth operator, the woman, as opposed to the Black male lawyer. So there are inherent unconscious biases we bring to the table. Dr. Latimore, with that in mind, what are some of the things that we can do to really combat the structural racism that exists, whether it's in our medical system or in our society, that ultimately will impact our medical system today? What are some of the things that we can get to address that?
Well, I think it starts with a conversation and listening with the understanding that you might be wrong. I think there is a lot of the way that we think about communities of color that we don't quite recognize are intrinsically racist. So this idea of resilience, it's a little controversial for me to say, given what we've already mentioned, but resilience is, instead of trying to build up resilience, it's a symptom of oppression, addressing the oppression itself, which was mentioned by Dr. Malawa, it is important, but then to recognize that believing in, well, you just have to work hard enough and you can make it, this idea of exceptionalism is a racist idea in and of itself. So it's kind of hidden. It's woven in between the way we think and talk about things. And it starts with a conversation and listening to those who've been impacted.
And I think with that in mind, Dr. Chokshi, when you look at things like post-traumatic stress disorder, ADHD, anxiety, learning disabilities that may occur, as we talk about the infants now, because we want to break that generational chain, right? And I'm going to get to Dr. Malawa on that point, but I want to ask you, especially because I want to go back from that late adolescent, thinking of going to college, having to start interacting with, partners, whether regardless of their sexual orientation, and what do they take from those relationships into that stage, and how can we break that cycle? And so whether it's a diagnosis that we know comes from that trauma, or things that go unrecognized.
Yeah, I think a lot about how to break the cycle of the intergenerational transfer of trauma, particularly with my work in the Healthy Generations Clinic, because we have the privilege of taking care of parents and their kids, which is not something we often get to do in pediatrics. It's a really unique model. And for us, what we see is, and I was just listening to a talk by Roy Wade this afternoon, who's really a leader in this field of childhood adversity and trauma. And I think what we need to do is we need to create systems that support families, and we need for them to be trauma informed. And so trauma informed parenting groups is something that has really been coming to terms, and home visiting programs are also important. But when I say this, there's an idealistic effect to what I'm saying, because just because the programs exist doesn't mean that they're meeting the needs of patients and doesn't mean that they're accessible. And so I think I have to go back to my original point of involving our patients and their families, because I think part of what we have to do in all of this work is to talk with our patients and their families, and also help educate them on how racism may be affecting their health, and help educate them on how trauma may be affecting their health. Because what I've been finding more and more in the recent past, as I've been doing more and more research in this field, is that we as healthcare professionals are really sort of, galvanized by the research on trauma and the neurobiology of trauma and the effect on health outcomes. But when I talk with my patients about it, they have not heard about this. They don't recognize the connections. And I think it's a sensitive topic, and we really have to do it in a respectful way. And to date, I can only find one manuscript that talks about how to talk to patients about trauma in a respectful way. And so I would encourage us all to think about, in the individual work that we do, how do we help patients understand this connection? Because to truly partner with them, to collaborate with them, requires that they understand the same thing that we understand. And I think right now we could do a better job of doing that.
All right. And Dr. Malo, as we start wrapping up, these are always great conversations. There's no doubt about it. But the surgeon in me is not going to allow us to leave here without making sure we give clear direction to our audience. I am a Black male living in the middle of the trifecta of this trauma. And as I said, the core and the center of my universe is a Black woman. What advice can each of you give to us as Black men to make sure that we are supporting making this better, making the life of the Black woman during and after pregnancy better, and also participating in making sure that family unit is also lifted up and better as well. So I'll start with you, Dr. Malawa.
Well, I guess what I want to say is that, I want to again acknowledge what Black men are working against. And I know that this is not at all what you were trying to imply, but very often I feel like Black men get pathologized for being absent fathers, when A, the data shows that in general Black men are some of the most present single fathers out of any race group of people. But B, they're up against some really hard structural racist issues in this country. And so, the first thing I just want to say to any Black men on the call is, like, you are enough. Like, legit, you are enough. And I wish you luck in dealing with all of the really hard manifestations of racism. As a Black mom who has a Black son, it has been really difficult to describe to my son in a way that keeps his spirit intact what all the social unrest is about. How do you start to talk to young Black boys about what has been happening with police and Black communities in a way that helps them feel excited and proud to be Black, right? And this is not anything new for folks who didn't know. This is something that Black communities have been dealing with forever. So I just want to start with saying that y'all are enough. But I also want to encourage men in particular. We live in this society where men are really encouraged to not engage emotionally. And what we know is that this society produces trauma for Black folks in particular and Black men in particular, and that trauma has an emotional impact. And if we cannot start to recognize the ways in which that trauma is impacting us, all of us, then we might run the risk of creating more trauma for other people around us, or just not even being able to show up in an emotionally present way that folks might need. And so I guess I want to say to all people who are experiencing marginalization to make space for the hard emotions that are happening right now, and to not feel diminished if you are experiencing hard emotions and can't tamp those down. And I just want to reiterate that we are enough.
All right, thank you. I certainly feel better, I got to tell you. I appreciate you articulating it in the manner in which you did, especially as a father of a 16-year-old son and a 14-year-old daughter. I think I get an opportunity every day to see the dynamic in almost every single thing they do, how differently people treat them based on gender and based on their commonality of race. So I think you make a very, very good point. Dr. Chokshi, any advice as we begin to wind down?
Dr. Malawa said it perfectly, because Dr. Frederick, the first thing that came to mind is that in our generation's clinic, we often don't see dads engaged. And that's not because they don't want to be. And truly, if I'm being honest, it's because many of our services are geared towards the mothers. And so what I really wanted to say is that, you know, Black fathers are important. Fathers are important. We should all engage with each other. And, you know, we should proceed with love and from, you know, acknowledging each other's strengths as we do this work together.
And I obviously feel like I come from a different generation. You guys look like I probably did some 30 years ago, Dr. Cooper Owens. But when I think of this, my first child, I went to my dean and I told him I was going to take paternity leave. He's the father of 8 kids, and he looked at me like I had 2 heads. You know, what is paternity leave? And at that time, obviously, that was not something that was acceptable, so to say. You know, and it does reinforce the wrong type of stereotypes and behavior, you know, and to the points that have been made before, that's already a disconnection from my child and from my wife that somebody else was attempting to impose. I kept my job and I went and was there for the birth, but it is an interesting perspective as well, and that we don't necessarily create in the medical services a space for fathers to participate. Dr. Latimore?
I would add to this great list that Black men have a very important role with mentorship, and there's a lot of power and advocacy as well. So going out and you know, identifying policies that are discriminatory, that facilitate inequity, and advocating. You know, there's a lot of healing just in that. And in terms of mentoring, our young people need someone who looks like them, who is successful, as something to aspire to for their future. So mentoring, I think, is another important component.
Yeah, and I appreciate that issue as well. I mean, I think the pillars of our society, unfortunately, are often overlooked because they live right in our communities, and they're not necessarily on our television screens or on our basketball courts or on our football fields. They're right in our communities, and we have to take the opportunity every time to lift them up. So I appreciate that. And Dr. Cooper Owens, you're going to take us home with the advice. Again, just to show you that you're not interloping here. Humanities is the backbone of the solution. I keep telling people, humanities and social sciences, in my opinion, is the solution to our future, in my humble opinion.
And I agree. I'm not going to argue with you on that one. You know what? Everything you all have said it needs to be repeated from the mountaintops. So I'll add, I am sometimes really disheartened by 2 things. The adversarial positioning of Black men and Black women against each other. And it doesn't have to be that way. We all know that we are experiencing trauma and pain. And so just by acknowledging we don't have to necessarily compare, but how do we work together to build a much more intact and healthy community? And that encompasses everything that has been said, because the maternal and infant crisis is not just involving the people who are birthing children or pregnant, it's involving all of us, right? And so that's number one. The other is emotions do not need to be gendered. I'll just end very quickly. I lived in Brooklyn. And as much as I love DC, Brooklyn kind of took my heart a little bit as well. So and I lived in Bed-Stuy, and there was a street harassment, anti-street harassment campaign started by a Black woman. And one of the pictures was of a Black man, and it said, "Black men can be soft." And I knew that it would have been tagged or destroyed by the next day. And I remember my husband and I drove by, and I said, look, they literally, whoever it was so offended by just the word soft that they destroyed soft. And I'm thinking, softness, empathy, compassion is not something that is biologically available only to women or women identified people. We're human beings. And so gendered emotions is a threat to our society. And I would just want men to lean into all of your emotions. That's what makes us human, and that's what makes us whole.
Yeah, well, again, I appreciate it. I appreciate your expertise. I think you guys have been absolutely fantastic. Your data, your information, your interventions are exactly what we need. I think this is a very, very important discussion. I'm going to close on a very, very personal level. My grandmother was a mother of 10 kids, and my mom, while the mother of 3 kids, had 4 miscarriages to have 3 kids. And in retrospect, she's a nurse. As she looks at the care that she got around her pregnancies, it wasn't directed at her in a way that would have allowed her to carry those pregnancies through. No interventions, no mental health support, no emotional support of any kind. That's just what women had to do, and you had to get through that. I was at the birth of my first child, and I remember my wife getting an epidural and someone commenting that, she was probably being weak by getting an epidural. And so it is a constant, ongoing situation that manifests itself probably right around the birth. But as I think pointed out here, it has a long history, a long tail to it, and it carries on well into the life that these children then live. However, there's a solution, and I do want to underscore what was said earlier. We all have the ability to love, and we all have the ability to give of ourselves freely. And while we can have legislation and we can have major institutions put up infrastructure, I think we have the ability every single day to do something different. So one of us, if not all of us, are going to run into a pregnant woman we do not know sometime in the next 24 to 48 hours. And I hope that each of us after today will stop and tell that person just how much we appreciate them and what they have done and what they go through. So thank you very much, everyone. And thanks for listening in. And I want to thank the mayor again for not just her support in general for what she's done for the city, but also what she continues to do in general on these issues and on the overall healthcare in the city. Thank you.